So what we see, ever here, you're watching ER or something, they go, sir, his pupils are fixed and dilated. Well, what that means is we know that pupillar constriction comes from Edinger-Westphal nucleus, right? Edinger-Westphal nucleus is in the midbrain. So if a person's pupils are dilated, it means there's no input from the midbrain. If they're fixed and dilated, meaning you're shining light and they're still not constricting at all, there's really no activity in the midbrain. So if you have no activity in the midbrain, you are in really serious shape. So fixed and dilated pupils, for that reason, are a sign of brainstem death. And of course, that's not a good thing. People don't do well without a brainstem. And by the way, no brainstem is not consistent with life. So I was being a little sarcastic, but I thought maybe I should clarify that. Ades pupil is, these are just quickly disorders of pupil function that might confuse you a little bit. Ades pupil is just called a tonic pupil. Think of it as just a spastic pupil. You shine light in, doesn't seem to constrict, and then it constricts really slow. Then you take your light out, and it just opens really slow. Just a slow pupil. Again, I'm not going to do too much with the diseases, because I know Don's going to do that, and I want to get to the actual examination part. Argyll-Robertson pupil reacts only to accommodation, not to the direct and consensual light reflexes. So what we wind up having here is you shine a light in the eye, no constriction. Shine the light in the right eye, look in the left eye, no constriction. Do accommodation, you get bilateral constriction. So just like we talked about with the Marcus Gunn phenomenon and the swinging flashlight test, here you have a patient that has accommodation, that the pupils will constrict. In this case, the eyes will in the other case, the eyes will converge. In this one, they'll constrict. It's both cranial-free function. Yet, with the Argyll-Robertson pupil, there is no direct or consensual light reflex. At one time, if a patient had that, they were considered to have tertiary syphilis. And now, once again, we find that other diseases, and including multiple sclerosis, can cause that, or a diabetic complication. Now, we mentioned briefly Horner syndrome. So what is Horner syndrome? It's paralysis of the cervical sympathetics, right? If you don't have sympathetics going up into your head, you have Horner syndrome. And as I mentioned, often that's due to an injury to the neck and yields compression of the sympathetic fibers. Now, one of the things you get, these are the four things that you can find with Horner syndrome. One is this very mild ptosis. And because, again, the superior tarsal muscle is a smooth muscle, and it just gives a little bit of tone to that upper eyelid, and so when you remove the sympathetics, the upper eyelid flattens. That little bit of flattening, when you're looking directly straight at a person and measuring eye to eye, you'll notice it. And so, or you might say, oh, ptosis, cranial nerve 3. So you got to be very careful about that, because this mild pseudotosis, sometimes it's called, can be caused by, again, Horner syndrome in the sympathetics as well. The second thing we see is unopposed pupiloconstriction. So because the sympathetics dilate, if you take them away, the pupils constrict. So you're going to see very small pupils. And then the next thing, and these two, by the way, are going to the eye, right? So those are going to follow the internal carotid, the first two. So the sympathetic fibers that follow the internal carotid are those that will be responsible for paralysis of the superior tarsal muscle, but they'll also be responsible for paralysis of the pupiloconstrictor fibers. Then we go to the ones that follow the external carotid artery, and those are going to go up into your face. And so you have two things that innervated in your face. We know that your capillaries are distal to that, your arterioles, proximal to that, have sympathetic innervation, so they can constrict and they can open. If you remove the sympathetics, then they dilate. Because I'm actually talking about the sweat glands here. It's the next one about the. I'll just put it up there. So I just took it out of order. But so what happens is the blood vessels in your face dilate on that side because they're not constricted. Well, what do you think a whole bunch of blood in that side of your face is going to cause? It's going to cause that face to be warmer and redder. Okay? So you're going to see this sort of flushed half of the face with some warmth to it, and that's because the blood vessels are dilated. And then the final thing is the sweat glands have lost their innervation. So you're going to find this anhydrosis. Is she here today, Ann? Are you at the webinar? No. Anhydrosis, again, hydro, water, osis, condition of, and without. So facial anhydrosis is a condition of no facial water or no sweating. So you have this hot, red, flushed, dry skin, due to the Horner syndrome if the fibers that follow the external carotid artery are involved. So if you have a Horner syndrome a little lower, you're going to have all 4 of these things. If you have a partial Horner syndrome, if it's, let's say, just on your internal carotid, you might have only the ptosis and the pupiloconstriction with no anhydrosis or dilation. And likewise, if you have a lesion affecting only the external carotid, you would have only the facial anhydrosis and ipsilateral vasodilation. I don't know, somebody popped a question up there, and I'll try and get to all of them later, but as that one came up, let's see, I had a check. What is the incidence of Horner syndrome by age groups? I don't know, I just can't answer that. It's pretty rare. You don't really see a lot of it. You'll see it in, like I said, neck tumors. You'll see it in patients with injuries, stab wounds to the neck, things that are not going to wind up in the chiropractic office on a regular basis. So it's not something I've even seen all that much of. And we mentioned the partial Horner syndrome. One final thing, and this is almost probably insignificant, but there's a tiny little sympathetic muscle besides the superior tarsal muscle called the muscle of Mueller, and it pushes the eye forward. I have a friend that's a veterinarian, and I was told that in other animals, particularly cats, this is much more pronounced. That when they have paralysis of the sympathetics, their eyes sort of sink into their skull. In the humans, this muscle of Mueller is so small that it causes a sinking back of the eyeball, which may make the lid look like it's even more ptosis. So again, we have more pseudotosis. Well, we have that slight ptosis with the superior tarsal muscle, and then we have this to add to it, the sinking in. So the paralysis of the sympathetics causes this ptosis-like condition via those 2 mechanisms, the superior tarsal and the muscle of Mueller. So, let's talk about now how we put this all together and examine this patient. The first thing you ask yourself, I like to, when I'm in a room with a patient, particularly there's 2 different kinds. You have the primary practice of chiropractic. And if you miss something on Monday, you're probably going to see him Tuesday or Wednesday, and you can go, oh wow, I forgot to do that, I'll do it again. But sometimes you work as a neurological consultant. So you have a chiropractor call you up and say, hey, Bob's been dizzy, or I've got this or that going on. Would you mind just taking a look and tell me what's wrong with this guy? Well, you're probably only going to have 1 shot at that patient. Or if you do a follow-up, it might be 4 or 6 weeks later. So I like to stop and just have something in my head that I can think so I don't forget anything at the time. So when I want to remember how to evaluate the ocular system for cranial nerves, I break it into 3 basic questions. Question 1, what do the patient's eyes look like? So I'm sitting here, I'm looking, what do the eyes look like? Number 2, if I can climb inside the patient's head and sit in their brain and look through their eyes, what do they see? And then the third part is, what does the eye look like on the inside of the eye? And that's your ophthalmoscopic examination. So in order to break these down, then you'll say, and I talked about that earlier, you put light in last. So the first thing you say is just what do the eyes look like? So you're sitting there, you're doing a history with the patient, and you're looking at them. And while they're talking, well, doc, I was having cheese in the morning for breakfast, and their voice goes, whoa, 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 whoa. And you start just looking at their eyes. And this, you want to check for eyelid ptosis, and we've talked about now all the things that go with this. Now keep in mind, besides neurological reasons, there's a ton of reasons that people can have ptosis of the eyelid. And so I just listed them here. We've talked about just these 2 really, maybe this one here. Talked a little bit about neuromyelitis. The next thing is, are the pupils equal? Does the patient have anisocoria, unequal pupil size? So size, shape, and equality of the pupils. So here on screen left, we have a person with ptosis. Now, by the way, and this is very, very important, some people have a facial look to them, like bedroom eyes. And other people have wider looking eyes. And some people have epicanthal folds. And so when you just look at a person's eyes, you could be fooled by their facial characteristics as to whether or not that's pathologic. So one of the absolute essential things to know is that eyelids can come down. Now normally what happens is, this would be, let's take this as a normal eye. Normally the upper lid is going to cut across the color part of the eye, the iris. The lower lid is going to form a tangent, meaning that, you know, a tangent is where a circle touches sort of a straight line. It's not really straight. But they're just basically going to skim the bottom. And remember, this border between the white of the eye and the color, we're going to call that the limbus. So when we look at the limbus, we want to see that the limbus is, we don't see any white above or below the eye. A little bit of white below the eye is not that uncommon. In fact, I have that. But you don't want to see white above the eye. If you see white above and below, then they have exophthalmos, their eyeball sticking out. You should never, unless the person is really pushing, you should not, when normally looking ahead in the distance, see sclera above and below the eye. That's always exophthalmos. But here's another great rule, just like that one, for ptosis. The upper eyelid can come way down and be normal, but as soon as it blocks any part of the pupil, it's pathologic. Because what would be the point of having a pupil if your eyelid was blocking it? So it's never normal to have the eyelid coming down blocking the pupil. That will always be a pathologic finding there. Then over here we have, I think I was trying to show anisocoria. This is a little bigger pupil than this one. So you're looking at the patient while they're talking to you, and you're looking to see, they have ptosis, can I see sclera above and below? As the amount of sclera laterally should be about equal. And of course you do this during the patient history, but if there's a problem or a question, or they're having bad headaches, or they're complaining of double vision, you do a much more formal evaluation of that. But as just a screen scanning, you can usually just look while you're talking to the patient. The next question then is, what do the eyes look like from the outside? And by the way, I thought I had slides on this earlier. I didn't see them go by, so I want to make sure that we cover this. And I mentioned some of it. You should have an equal amount of sclera. I'm pretty sure a slide's going to come up showing this with little arrows, but I want to say it now just in case I remove those for some reason. We want to see an equal amount of sclera on either side, possibly a little sclera below, but probably no sclera above or below. Also, when you do ocular motility, when you ask the patient to look to the right, look to the left, how far are you supposed to go? You always go at least until the limbus approaches the canthus. The canthus is the corner of the eye. So you don't want to see any sclera when this eye is looking nasally, and you don't want to see any sclera laterally when the eye is looking temporally or laterally. You want to at least go far enough. Now if you go further, that's okay, but sometimes people develop physiologic nystagmus. It's like they're just trying to go further, and that's not pathologic. So again, another thing about is the nystagmus pathologic or not, is nystagmus that starts in the midline right away, moving, is pathologic. Nystagmus that you get a little bit of jerk here or there at the very end of a gaze is probably not pathologic. So these are all, I mean, we could talk all day about nystagmus and this, but if you don't have these barometers for when does it mean something, I think that's where the experience comes in. The next thing you want to do, so you're looking at the eyes and you're measuring sort of what we're going to call limbus to lid and limbus to canthi, right? You're measuring the distance between the limbus and the lids, looking for sclera, and you're measuring the distance mentally, not with a ruler or anything, from the limbus to the canthus. So we call it limbus to lid, limbus to canthi distances. Now you've looked at their eyes, you looked at the pupil size, shape, and equality. You've looked at the limbus to lid, limbus to canthi, and you feel that the eyes are aligned normally. Next you want to jump in their head and look through their eyes. There's really three things that you do when you want to look through the person's eyes. One is ocular motility, right? How do you know what they see unless you know where their eyes can move? And so you do your ocular motility. The next thing, again, I'm going to skip some of the clinical comments, leave those for Don. This is just the relationship and how a person can have an ocular deviation, cause it to tip their head and wind up with neck complaints that bring them to the chiropractor. So when you do the ocular alignment test, you're going to ask the patient to just look straight ahead in the distance. As a person focuses closer, remember the pupils constrict. So if you try and do your test too close, they're going to look constricted. Oh, here we go. The upper eyelid covers the blah, blah, blah. We talked about this is limbus to lid and limbus to canthi distances. The lower lid forms a tangent. The same amount of sclera. Here's the slides I was looking for. So there's the limbus, and there's your limbus to lid. Okay. So the limbus, the dark line, limbus to lid, and then limbus to canthi is these little arrows in here. So there's your limbus. There's your lid. So we have limbus to lid. There's your limbus. And there's your canthi. So we're measuring these distances mentally. And as I mentioned, when you completely abduct or adduct the eye, you should move it at least until the limbus meets the canthus and there's no sclera available. This slide here is showing epicanthal folds. Some people just have folds of skin that cover the sclera, and so it makes them look cross-eyed, if you will, or like they have strabismus, the old term for cross-eyed, or really any ocular deviation. But in reality, there's nothing wrong with the ocular alignment, it's just the skin. Some people have trauma and scar tissue that makes the eyes look malaligned. So if you have a question about the ocular alignment beyond limbus to lid, limbus to canthi, there's another test we're going to talk about in a couple of minutes that will really help. It's actually an excellent test. And these down here, I'm listing things that might confuse you, that might make it look like the eye has incorrect ocular alignment, but in fact it really doesn't. Good. The corneal reflection test is what I'm going to talk about a little later. There's another reflex coming up here, or that we're talking about, called the ciliospinal reflex. Now, it's ciliospinal reflex. And really, it's something where you just want to test the sympathetic. So you think, maybe this patient does have Horner syndrome. This just doesn't seem right. They have a little ptosis. The face seems a little red or hot on one side, etc. So what you do is you want to test it using a reflex. Well, pain causes a sympathetic burst. So if you hurt them, their pupils should dilate. And that's basically what you do with the ciliospinal reflex, is you pinch them on the neck, typically. It hurts, their pupils dilate, and then you see, oh no, they do have good dilation. With a Horner syndrome, that's paralyzed. You can hurt them and their pupils won't dilate. So now we're back to what can the eyes see? So we talked about ocular motility, but we have two types of vision to check: central vision and peripheral vision. Now we test central vision with the good old Snellen eye chart. So the Snellen eye chart, what do we do with the Snellen eye chart? We put the patient 20 feet away, we ask them to cover one eye, and we're going to compare them to what a normal person can see at 20 feet. And so the first number is what they see, and the second number is what a normal person would see. So 20/20 means that your vision is exactly the same as a normal person. 2200 means that a person can see at 200 feet what you can see at 20. So you've got terrible eyes if someone else can be 10 times further away and read the same line. So in neurological terms, blindness is complete absence of the perception of light in an eye. But in legal terms, blindness is described differently, and usually 2200 is legally blind. I might have a different number coming up in a slide here, but that's what my recollection is. If you have questions, and by the way, you don't have to use 20 feet, you don't have to have some giant office. They make these little cards that are exactly 1/4 the size, so you just hold them at 5 feet. And again, you always occlude the vision of the eye, and you also allow the patient to wear their corrective lenses. You're not going to go in the back room and grind them new lenses, so you want to test their corrected vision, not their uncorrected vision. If you think, based upon your central vision testing, that they have a new problem that has not been identified, of course, that's in the realm of the optometrist or ophthalmologist. You test each eye separately, and medical and legal blindness. The next thing you want to do, so you've tested central. Remember, we're climbed in their brain, we're looking through their eyes. So now we just tested their central vision. We know that the macular vision, the color vision, the best vision they have is 20/20, let's say. And by the way, I don't do a lot of central visual testing because most people know. They go to the optometrist once or twice a year. They have glasses. They'll tell you my eyes are blurry. This old thing, I remember in chiropractic college, they said, a lot of times people are going to come in with headaches, and you'll find that they just need new lenses. That really does. People aren't that stupid. They usually try that. What I get is a lot of people saying, I thought maybe it was my lenses, and I went and had my eyes checked. So people usually figure that out before they show up in my office anyway. The second type of vision that you want to test is peripheral vision. Now, over the years, I've changed how I do this based upon a colleague of mine, Dr. Hines, a medical neurologist, who I thought had a much better way to test it. But I'll start with the old-fashioned, basic, good way to test it, and then go to a much better and faster way. The old way we called confrontation. So you just stand in front of the patient, scream in their face, can you see peripherally or not? No, that's not what you do at all. So you're going to be in front of the patient. That's why you have to be in front of them, because when you test a person's peripheral vision coming in from the outside, I should probably pop the camera up so I can see what you guys see on this particular thing. Oops. I guess that's not going to work. I think I just shut the camera off, didn't I? There we go. Try that. So if I want to test the peripheral vision here, if the person's looking straight ahead, how do I know they're not doing this? I don't know if you guys can see. Don's got a pretty good, but not moving the head, but I'm just darting my eyes. So if you're sitting in front of them, you can see and say, no, 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 look right here. You're looking away. I need you to look right here. But if you're standing behind them and coming in from the outside, or you can't see their eyes, they can move their eyes, and that ruins the test because they're not really testing peripherally, then you're testing central vision. So you basically, in the old-fashioned way, you go nose to nose with the patient, basically, not touching, of course, but maybe 2 feet away. And then you ask them to occlude an eye, and you close your eye. And this gives you a nice barometer. You come in from the outside, go back from the outside, and you're going to titrate your vision against theirs. So you take their optic field and you divide it into 4 quadrants, just like we did when we were looking at visual field defects. And you want to test the center of each quadrant. So if I was testing my right eye, okay, I'm going to have and I'd be testing really the left eye of the patient. And so I'm going to occlude, you have eye to eye with the patient, and then you just come in from the outside and you say, tell me when you can see my finger. And you start wiggling your finger and bring it in, because the wiggling finger is a little easier to see. And they'll say, oh yeah, I see it. And then say, okay, point to where it is. And they'll go like that. Now they can see part of your arm, so it's not great, but the pointing helps that they really are seeing it. But the real barometer as to whether they just think they're seeing it, remember in cortical blindness, they can say, yeah, I see it, and be completely blind. So rather than just take the patient's word for it, you want to do a little reliability check. So what you'll do then is stop wiggling your finger and say, now tell me, is it wiggling? And then right as they say no, start wiggling it, and then they'll go, oh yeah, now it is. And then you know they're really seeing what you're doing out there. They're not just seeing a shadow or your arm coming in from the outside. And so you'd come in the center of this visual field, the center of this visual field, you come this way, and at least check a little wiggling finger. And by the way, if you don't want to use a wiggling finger, the best, easiest to see object is red. So a lot of people use a pencil with a red eraser, or even put a little red ball on the end of a stick and use that. That's a very much more sensitive way to do it. So here you check 1 quadrant in each eye. The patient can see it. You switch to the other eye. You do the same thing. Now you know their central vision and their peripheral vision are functioning. Now the better, quicker way to do it is called simultaneous double confrontation. That's just one term for it. And basically what you do on that one, and I really like this, Dr. Hines, but what happens is Dr. Hines was saying that you really don't need a lot of retinal cells to do it the old-fashioned way. So what you want to do instead is have the patient occlude one eye and come into 2 fields at the same time, and rather than a wiggling finger, put a number. So go like this, just for that long, and say, how many fingers did you see? And they better say 6. And then you might do a 2 and a 1, and then they'll say 3. What's happening then is they're perceiving 2 at the same time. It's more of a challenge for them, and you know that they're accurate, they're really seeing because they're giving you a number. It could be anywhere from 1 to 10, obviously, although you wouldn't really use 10s. So maybe 1 to 8. You might do something like that. I guess you'd always want 1 finger, so just do 2 to 8 would be your options there. So that works very well. It's very, very fast. So you're stimulating 2 quadrants at once, and you're asking the patient what they see. It takes less time, and it's probably a more sensitive test. And anytime we can get a better test done in less time, it moves up on the scale of utility. So let me show current slide. Okay. Yes, that is for the peripheral field testing. So we have the central testing, Snellen eye chart. Peripheral, we use this confrontation technique. Now the only other thing that I would add to, I'm not going to bother, this has to do with what we talked about yesterday. There's a visual extinction, and I sort of showed you some pictures of that with the constructional where the person couldn't draw anything on the left side of the world, so I'll just skip this slide. And again, that's an agnosia, and it's in the parieto-occipital cortex.